Guys, Episode 5, Crowning the First Honorary Dental Guy with Jeff Lineberry. On this week's show, we discuss PPO to fee-for-service transitions with a fee-for-service veteran, TMD treatment with a spear-trained TMD expert, and 10 products you'll not want to miss. All this from one guy? That's right, this week on The Dental Guys. Welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
We're excited you're here this week. We've been preparing for this show for quite some time, and we're really excited about this show because we've got a great guest today, and this is a really fun thing for us to get to do, to bring someone else in who's really an expert in dentistry and get to share what he knows about some things with you guys. Kind of a crazy story about how we got Jeff, who's going to be on today on the show. We were going out to Spear, as we've told you guys a couple weeks ago, and we got an email. I got an email from Spear saying this is one of your mentors for the Spear class, and I noticed the name. I saw the name Jeff Lineberry, and I thought, I know that name because where I went to undergrad school, he practiced there, and so I knew his name from that, and I'd actually kind of randomly had some friends that needed a dentist there, and so I kind of looked up dentists. I found his name, looked him up. He looked legit.
So you referred to this guy?
Yeah, I referred some patients to him. I didn't know who he was, but I referred patients to him, and they loved him. They really did, and they're kind of hard to please, and they really loved him. They were really sad because he actually moved to start a new practice, take over a practice, and so then when I got the email from him, I thought, wow, this is really cool. But then, of course, Wes and I were talking about this as soon as I told Wes that, and Wes is like, maybe we should try to get this guy on the show if he ends up being somebody.
Right. Now, when we went out there, we were thinking, well, maybe we could ask Frank Spear, but he wasn't even there, which was fine because that's excellent. Fine. It was awesome, man, total awesome. But we had to ask somebody. Yeah,
and we wanted to ask somebody who.
And since you knew him, I thought that would be cool.
Yeah, we felt we could talk to, and so that was kind of how it all happened. And so let's bring Jeff into the call. And Jeff, welcome to the Dental Guys.
Oh, thank you. I appreciate the invite for coming in and talking to you guys.
Yeah, we're excited to have you here. And so Jeff, tell us a little bit about, first of all, where you practice. Where's your practice located?
Currently, right now, I'm practicing in Mooresville, North Carolina. It's a town or city just north of Charlotte, North Carolina, and it's also known as Race City, USA. So, real popular for NASCAR.
That brings up the first question, which is, do you have a favorite driver?
Well, I come from the old school, so I was a Dale Earnhardt fan growing up, and of course, obviously now.
I'm not going to tell you whose fan I am. I'm a Jeff Gordon fan.
Oh, man.
Okay.
So that's bad, man. Rainbow Warriors.
Yeah, hey, he's a great guy. So
this is last year, man. Can you believe that?
I know, it's hard to believe. It seems like he just got started.
North Carolina is kind of a special place for dentistry, right? Wes, you want to talk about that a little bit?
Well, North Carolina happens to have it's like one of these states that dentists really don't, they kind of feel like, man, I got to go there and I got to take patients to this. They're kind of like their own little club. What is up with that, Jeff? I mean, come into the world of like CERTA or NERB. I mean, no one wants to take another test. People come from Tennessee and they're like, I'm going to go retire to the Boone, North Carolina region or Linville area because it's beautiful. But guess what? I'm 50 years old, 60 years old, whatever, and now I got to take another test. What in the world? Tell us a little bit about that. Why is North Carolina so special?
Well, one of the things is that actually until recently they actually do offer license reciprocation, which they used to not do that up until a few years ago. So that's definitely a plus, and I think that they're still a very conservative, I guess, old school kind of thing. So they're still kind of, I guess, battling in the ways of the old, and
yeah.
Yeah,
so it's special. What you're saying is it's special.
We're special.
It's okay. I mean, that's a good thing. I mean, but they do have, you can get your license there by reciprocity now. They do have that.
Yes, yeah.
Oh, okay.
Well, that's something I didn't know.
Yeah.
But
So they've come into the 21st century.
right.
Yeah, we're getting there. You know, they're actually allowing CETA tests now.
Oh, that's cool.
So,
Okay.
yeah, so yeah, they're getting there.
All right.
So
So
Cool.
Jeff, let's kind of get into kind of how we're going to handle this this Dental Guys episode. Is we have kind of set up this to where we're going to discuss 3 different topics, and we're going to give ourselves a little bit of time for each topic. And the first topic that I'd like to discuss, and this is something that is near and dear to your heart, and how you've really done this a couple of times now, and is how to handle dental insurance. And that's topic 1, but specifically, how do you take, being that we like to practice as dental guys at a very high level, how do you take a PPO practice to a fee-for-service practice? And you did this in Boone, North Carolina first. How do you do that?
Well, it's not an overnight process. Let me just put it that way to you. It's one of those things that when I first got started in Boone, I took over an existing practice, but the doctor that was there, he actually had passed away about 6 months prior to me getting there. And so there were still some patients there, and lo and behold, I thought it was a good mix of patients. And when I actually got there, a majority of the patients were actually Medicaid. We did have some fee-for-service, and there was a mix of insurance. And that was my drive and desire, was to be insurance-free. And so it's one of those things that's where I started off with. And like I said, it's not an easy process to go through. It was probably a lot slower than what it would have been if I'd gone through and took on insurance plans and PPOs and other things, which, you know, they all guarantee, or pretty much they want to, you know, get you engaged with getting you new patients. And but for me, it was one of those things of just developing relationships with patients and developing values and engaging the patients in the whole process of it.
So did you buy this practice outright? I mean, was it an established practice or that you bought? And
yeah, it was. Go ahead. I'm sorry.
Well, you know, the main thing is that you've started working in this practice, and now you're going to start, you know, establishing, you know, what your values are and you know what you really like to do as a dentist. And you're coming into a new practice. Did the old dentist did he leave and then you took over? Or how did that happen?
You as far as the previous practice, of course, the dentist actually passed away.
Oh,
and my current one, I purchased it. So
Gotcha. So when you said the practice started off as a Medicaid or had some Medicaid, had some fee for service, and so at that first practice, the one in Boone, you pretty much just from the beginning chose that you were not going to get involved with PPOs at the time you started. Is that right? So you never really got into that?
Right, yeah. When I was there, I mean, it was one of those situations that I saw the landscaping of things as far as how it changed. But when I first got started there, yeah, I mean, it was, I took no insurance. It was one of those situations I kind of felt like that, you know, once you kind of start delving into the insurance part, at least for me, it was going to be a hard way to turn back. But if I started off with fee-for-service, focusing on quality, developing relationships with patients, giving them a different experience that they had at other places, then people would eventually find you and find the value in that. And that's how I started off. And for me, persistence did pay off. The current practice I'm in, they accept assignment of benefits. In my previous practice, we were full fee for service. So in other words, you came in, you had restoration done, or you had work done, you paid for it in full. We'd file your insurance for you as a courtesy, but you know, you paid us in full in the insurance company. The current practice is one of those situations where it's a split payment. In other words, we're taking that payment from the insurance company, and of course, the more involved you get with the insurance companies, the more it becomes a part of the decision-making process for a lot of patients.
Mm-hmm. Yep. So that process is different again, where you're having you had to, even though it sounds like all PPO, you had to go in and pretty much just immediately, it sounds like you dropped that. And how was that? What was that like? I'm interested to know what that was like, both from a staff standpoint And what was the reaction of your new team that you told them that? And then what was the reaction from patients that you saw?
Well, the good thing is that I didn't drop it right off the bat. I mean, it was one of those things that I transitioned it out over about the first year. I've been here currently for coming up on year 2. Okay. So I did slowly transition it out over that first year. For me, it was one of those things that still the staff. You asked what the staff's reaction to it was. Is that I think they saw the issues and concerns and problems with a lot of the insurance companies. The more that they got involved, you pretty much shaved your fees right off the top of it, and you just wrote that off. And so you look at what you got out of those patients as far as from a standpoint of, what care could you give them, what were they getting done, and just the overall value from that standpoint from the patient, but also when you look at the patient and their values and where they're at with things. In other words, is it simply dollars and cents, or is it about the value that you're trying to provide the patient? So it was one of those things that there again, I'm still in the process of training and bringing the staff into the belief. I think they're more on board now than they ever have been, and patients have becoming more and more engaged in not what their insurance simply covers, but about the value of what we have to provide for them, which is trying to help provide oral health for a lifetime.
When you went to Boone, was it harder there, or is it harder this time?
That's a great question.
What time? I mean, like time frame wise, and was it what year was that in Boone when you started?
When I went to Boone, that was actually in 2001. So that was during the peak years. 2001 was a little slower, but as you know, that was when we started seeing the great economic boom. Things were going great. I think everybody was seeing that. Then all of a sudden, for most people, it was around 08, 07 is when it really hit. For us, actually, we went strong all the way until 2010. And then it was like all of a sudden it finally either reached Boone or reached my practice or all above. So
it was harder, would you say, then or now? But I mean, Boone being in 2010, it hit hard there. So you were in Boone. So did that make this transition? Were you completely transitioned in 2010 to fee-for-service, or was it just...
Was I still at fee-for-service in 2010? Yeah, I stayed there. In other words, I mean, did I get more creative with my financing options and other things with patients? Absolutely.
Right.
But, obviously at that point I had, 8 or 9 years with these patients of developing relationships with them.
Mm-hmm.
And so it's one of those things that you work with them. I mean, before it may have been one of those situations where the patient paid for things in full, and then all of a sudden we may say, well, Ms. Jones, if you want to do that crown today, if you want to pay half today and half when you come back to see, we've been working with you for the past 8 or 9 years. We're good with that. And for a lot of patients, that was helpful.
Gotcha.
Good.
So.
Gotcha. So when you made that, I'm interested again, back in the current practice that you're at, when you did decide to drop PPOs that you did have there, how did you go about that with patients? I know it wasn't immediately. Did you talk individually to patients one-on-one? Did you have letters sent out to them announcing that this is going to happen? How did you go about making it aware, or making your patients aware that you were going to make that change? Because I know a lot of people listening to this are thinking, if this is me, how would I even, if they felt passionate about doing this, they got to start somewhere. How do you make your patients aware of this change?
Well, one thing before I ever went into this whole piece of it, as far as looking at dropping insurance or changing out a PPO, first and foremost, I think you have to know your numbers. In other words, you have to know what your practice numbers are. You have to know what your overhead costs are. You have to know your percentages of patients that are coming from different insurance plans. You have to know the numbers, because then you can look at, okay, where do you start? And obviously, the process or thought process that I would have is you start with the the worst ones. In other words, the ones that if you're only getting 3 new patients a month from a plan, and maybe you're only getting 30%, they're cutting your fees 30%, and you only got maybe 75 patients in that bunch, then maybe that's the first plan that you start off with. And you make it a transition. In other words, it's not one of those things that I wouldn't recommend anyone going out there tomorrow and saying, hey, I'm just cutting out all the insurance plans and we're going to be doing comprehensive dentistry starting tomorrow.
I mean, that leads really into this question right here. After this, you've done this twice now. What are the top 3 things that you would tell someone that they would need to consider prior to making this transition?
Well, like I said, first and foremost, one of the things, the biggest thing is you got to know your numbers. You got to know your stats as far as your practice. I'm always amazed a lot of times when you start asking and talking to other dental professionals. They're not very familiar with their numbers. They don't know how many new patients they have. They don't know what their overhead costs are.
How is that even possible? John and I have talked about this a lot, not really on the dental guys yet, but that's something we want to talk about is numbers and some of this. How is that even possible, John, that we have dentists that don't really know how many new patients? I mean, I can tell you right now what we strive for because we talk about it every month.
Yeah. Yeah, I don't understand how you don't know what your current overhead is. For instance, I mean, you and
I bounced that off. You asked me the other day. You were like, "What is your overhead?"
What's your overhead? Because that seems like so essential. So, it makes sense, Jeff, that would be the first.
So, a numbers game. One of the first things you need to do is dive in and find out, really, Jeff, what your true numbers are, where your new patients are coming from, what your overhead is, what your production per month has been over the last 12 to 18 months. Is that a good metric you would want to know?
Oh, absolutely.
Are the fee-for-service plans providing you patients? John and I have talked about sometimes there is some of that going on where they do provide you even some higher income treatment plans.
Yeah, some people use PPOs as kind of a loss leader even, as a way to try to just get people in the door and then do things that are more comprehensive with them. But it sounds like, the numbers, absolutely. That has to be. And probably too, you want to get a good, if you're not comfortable with the numbers, you want to have a professional CPA or some advisor that understands what the norms are, I guess, too.
Right. So Jeff, that number 1 is good metrics. What's number 2?
I think that the number 2 thing is educating and differentiating yourself. In other words, it's one of those situations that you can't simply say, you know what, guys, we're better than the office down the street. But then you're putting in your 15 clock hours a year online only. You're not trying to strive for better education, because ultimately, that's a part of it is that your team also has to believe in what you're doing. In other words, they have to sit there and go in the back of their mind, well, yeah, we are better, and we've got a great doctor that we're working for. We feel like we provide a great service for our patients, so they have to believe in it as well, because ultimately, without that, that's key to your support too.
Good. That's a good word.
That's good. So education, we talk about on the dental guys a lot, taking things to the next level, always educating yourself, surrounding yourself with people that are smarter than you, challenging you, and really that's one of the reasons why you've put yourself in the midst of Spear education environment. I mean, just being out there, I'm sure as a volunteer not volunteer, I'm sorry, that's what I am at UT, but as a faculty member there, you're surrounding yourself with great minds, and that's helping you. And then discussion amongst those tables that we set out, I can imagine how much that just takes it to the next level.
Oh yeah, I mean, absolutely. I mean, when you kind of start surrounding yourself around people that are trying to take things to another level, I think it's really powerful. And I think that as you climb that education ladder, that becomes more and more challenging thing to do. Is that you want to soak up and absorb more and more information, and then you keep striving to find those different areas, different people that you're going to seek that from as well.
Good. So 1, good metrics. Number 2, educate yourself and surround yourself with great people, a great team that believes in you. And number 3, what do you think, Jeff, for someone that would consider doing this to their practice?
I think then you have to you got to walk the walk. I mean, in other words, you can't just go out there and do it. I mean, you got to provide the values for the patients. You got to show them the benefits. You have to have, a high touch practice in the sense of you have to differentiate why your cheeseburger at your McDonald's is different than the cheeseburger and the McDonald's down the street, because a lot of patients, that's what they look at it is, John, my crown is the same as yours, Wes, and the same as yours, Jeff. It's just yours is this price and that price. So which cheeseburger can I get for the least amount of cost for a lot of patients?
That's perfect. That's perfect.
Yeah, that's absolutely right. It's a commodity mindset, and that's where our society, unfortunately, they get now. Sometimes it's funny because they choose things like that, and then there's other things that they choose not based on a commodity mindset. Things like I don't know which clothes they buy, brands that they look at, and they see that this shirt is not the same as that shirt, and really, there's something that goes into that we have to tap into, the understanding of quality, that it is worth paying more, and that but it's more for us than just that quality. It's got to be the experience, right? And it's not just a brand, although the brand can matter, but it's the experience that they come out of there going, well, I'm never going to go anywhere else other than this, and that's
I always told my team this, that the next call could be the next $10,000 case.
Yeah,
I mean, it could be. So you're always, and the person that walks in the door, you never know. I mean, I'll never forget the guy that walked in the doors and he was in overalls and he spent $70,000.
Yeah.
And you never know. You never know.
And, well, that's good words on that. I mean, that's definitely some good things you can take, because people, I think, again, they hear fee for service. It's such a buzz phrase these days for dentists who are trying to figure out where they are in the landscape. And it's even more, I think, of a buzz phrase once you start getting into dental education. You start seeing comprehensive dentistry, and you start asking, well, how can I do this kind of dentistry in a PPO practice? And it is hard to do that. And so I think people are thinking about it. This is some good framework. And again, we encourage you guys who are listening to the show, give us your feedback. If you've done this or if you've got things to say, we want to hear it from you guys. A second topic today, which I definitely am excited to talk about too with you, Jeff.
Yeah, I've been waiting for this for a long time.
Yeah, it's TMD, and temporomandibular problems are so common.
John, the first day that I got back and we're practicing, I text you and I'm like, does everybody have edgeware today?
Yeah.
Does everybody have pathway wear?
Yeah.
And then I was like, man, I just diagnosed a case and I just sold another couple $1,000s worth of dentistry. Actually, more than that, but it was thousands of dollars worth of dentistry because I diagnosed a problem on a full mouth rehab, and I was like, "Whoa, we got to fix this."
Yeah, and you start seeing things. You start seeing things, and I think that the thing that we certainly, both of us, Wes and I, want to get better at and continue to get better at is managing TMD patients in a way that is comprehensive but also practical. And that's really the thing: is you want to be comprehensive, but it also has to be practical for an everyday private practice dentist to manage patients who come in with these problems. So, Jeff, tell me a little bit about, on a Monday morning scenario, because so many times these patients come in, they're new patients in pain, and it's because of local muscle soreness or some type of kind of global muscle myofascial problem. And how do you handle those patients as they come in to your practice with pain, muscle pain? What does it look like in your practice?
Well, that's a great question. You're right. These patients do walk into your practice quite frequently, and where do you start? First and foremost, I think the most beneficial thing that you can do is do an excellent history gathering. I think the more you talk to patients, the more you start to understand some of the dynamics of what's going on. It's kind of like the best way I can describe it in dentistry is that oftentimes when you have a patient who comes in with a toothache, a lot of times, as you may find, that a lot of times before you even look in the patient's mouth or even look at the x-ray, you already got a pretty good idea by asking the patient questions. So the more information that you can gather, the better off you are. And then, of course, a good examination. You have to start dialing it down. Is it muscle, is it joint, or is it both, or one or the other? And so that's kind of how, as far as when the patient shows up, I do a thorough exam, gather information, thorough history, and then we start looking at where do we go from here.
Mm-hmm. If you determine that it is a muscle problem from that exam, which so many of these patients are, muscle issues that I think we see. I know you can't nail down exact treatment for one patient, but if you do determine that this is a muscle problem, is a typical way that you treat patients from a acute pain standpoint? Is it appliances? Is it medications? Is it a combination of both? If this is a patient that's in pretty acute pain.
That's a great question. I mean, sometimes, we'll definitely do medication sometimes, but oftentimes it is appliance therapy. And sometimes in the office, if we have enough time, sometimes we may make a quick appliance, something that may be an anterior appliance, anterior only resting appliance, that if it helps the patient relieve their pain until we get the appliance back from having it fabricated.
So something like a biplane or just some kind of disclusion device or something like that. Okay.
Yeah, absolutely.
And then combining that, so you see, again, sometimes with medications like muscle relaxing type medications. Is that what you're talking, or anti-inflammatories, or what are you typically prescribing?
Yeah, usually either a combination of anti-inflammatories and or muscle relaxers with the patients.
Some of these people have also advocated the use, and I don't in practice, is sleep altering medications like amitriptyline, things like that. Mm-hmm. Are you using any tricyclic antidepressants or anything like that?
No, you can use those, but it's one of those things that, I dig a little deeper into it. In other words, to me, I look at if there's a sleep related disorder that's triggering or causing some of the issues, or is it stress factors, even a lot of the newer medications out there, a lot of the antidepressants, the SSRIs, are actually increased clenching and grinding activities in patients. Mm-hmm. So we have to kind of look at the whole picture of what's going on versus just slapping another Band-Aid on it.
Sure.
Right. Do you feel like medication is a Band-Aid for a lot of patients and it's just to get you over the hump, or is it something that you feel like patients need to be on long term?
I'm definitely not a long-term medication guy. I'm one of those ones that I try to move away from it, see what we can do to alter the patient's lifestyle, try to improve their overall health, not just be another physician or another doctor writing them another prescription to get them over the hump, so to speak.
So if these patients are, again, taking that same scenario, acute pain situation, you've made them, say, an anterior disclusion device or prescribed as needed, that patient then, do they return, I'm guessing, for a more comprehensive evaluation, because if this may not be a comprehensive evaluation this first time, correct? This could just be a acute, specific muscle joint exam. They come back for comprehensive eval. And what types of things are you talking to that patient about if they do get relief from that anterior disclusion device? What's the conversation look like with them as far as your plan for them for the future?
Well, a lot of times at that point it's a level of engagement with the patient. In other words, where are they at in the ownership of their condition, but also, do they put two and two together? In other words, are they seeing the changes in relief as far as what we're doing for them and what we can do for them? And like I said, are they really truly serious about making some significant changes in how they feel overall, or is it just simply just get me out of pain today, and I'll see you next time when it's bothering me again.
Gotcha. So yeah, you have to see where they are and have them kind of be asking you for, is there a way to make this more permanent, or is there a way to make this not happen again? I guess is that kind of what you're saying?
Right. Yeah, it's part of, like I said, getting them engaged in it. In other words, oftentimes when they show up, I'll ask both of y'all, how many patients do you have walk in your door and say, "Doctor, I clench and grind my teeth and I have jaw problems"? Oftentimes we look at patients that have wear on their teeth. They have obvious issues that's going on, and we say, "Do you ever notice that you clench and grind your teeth?" And universally, it's, "No, doctor, I don't do that."
Right, I don't do that.
I don't do that.
We talked about awareness and creating value, and then you start feeling around on muscles and palpating things, and then things are sore, and they're surprised. Their eyes get big, and you say, "I'm really concerned about this tension, and how many headaches are you having monthly?" And then they're like, "Well, I have probably 2 a week." Mm-hmm. And you're like, well, that's not normal.
Yeah.
And so, you're diving down into finding out the real problem. And so whenever a patient presents, they've called your office, they've been, normally they don't, call, but occasionally you'll get this patient that calls with acute muscle pain and, even maybe some trismus, or, they're presenting with maybe even a little bit of lockjaw. And, you've got a Monday morning patient here that shows up. What amount of time do you allot for this? If your team is, Monday morning they get there, 8 o'clock, you get this phone call. I've been hurting all weekend. I can barely open my jaw. What are you going to do? Are you going to 30-minute appointment? How's that roll?
Oftentimes what I'll do for those patients is that we just work them into the schedule, and we quite simply just, there again, I think one of the important things when you're bringing patients in like that is setting an expectation up front. In other words, if you tell them up front, we're working you in, he's going to be in and out working around a couple of patients, and you'll probably be here for an hour, and he'll spend some time with you. I think you have to set the expectations for it. Obviously, if you got the time, that's the best way of it, is where you got uninterrupted time. But as you know, it's not always the easiest thing.
Right. That's good. That's good. So
makes sense. And that, it sounds to me like you are definitely incorporating that into your practice. Does that mean? There are people that kind of almost market themselves as a TMD specialist, who want to see those patients, even maybe as even kind of a referral, source. Hey, I want your TMD patients in my practice. Do you want that?
I've seen that on the bottom of signs, haven't you, John? Have you seen that?
That's why I ask. Is Jeff, do you look at your practice because you've had a lot of training in TMD condition and how to treat it? Do you look at your practice as something that you like to see more of that, or is that something that you just kind of you don't necessarily market that?
Well, actually, I do have some referral basis in my practice. I mean, I do get patients that are referred to me. One of the things that the most thing that I enjoy about seeing those patients that are having TMD issues is simply helping them. Oftentimes I've had these patients that have seen 6 neurologists. They've seen a variety of different doctors, and they need help. And, they come in, they're exhausted, they're wore out.
They're sick.
Mm-hmm. And, sometimes they just show up in my office for a dental exam, and I start going through and talking to them, and it's like, what can we do to help you?
Right.
So to me, that's more the basis of my drive behind it. It's not so much how many TMD patients, because I'll tell you quite honestly, I mean, when you start working with TMD patients on a regular basis, it is a very time-consuming process.
Yes.
It's not a fast process.
Right. And it feels like that, like I said, we came back from this, not that we weren't treating TMD before, but John and I have, practiced very similar in how we treat TMD on a very, well, let's just say superficial level, but, one of the things that, that we did there was when we went out to Spear, we came back and we felt like that you don't really even have to go looking for these patients outside of your practice. They're already in your practice in the hygiene operatory, and you're doing more and more intensive exams on the hygiene patient and even your comprehensive exams. And so that initial exam turns into what is treatment for TMD. And like you said, when you're trying to practice high level, you don't even have to go find them. They're already there. I wonder too, I educate a lot of residents. Every year we have a group of about 5 come through the residency that I'm involved in volunteering at. And, you try to help them understand how to treat basic TMD problems. And then you also try to point them where they can go and learn. And a lot of these people, coming out of dental school and stuff, they don't know. And then we've got some people that listen to this podcast that have been practicing for 10, 20, 30 years, whatever, and they want to take it to the next level. If you don't know what to do in the treatment that you're describing, Jeff, and that's foreign to you of what we're talking about here, where can a dentist learn good techniques? We don't want this to sound like a Spear Education commercial, because we don't think, we're not saying, everyone needs to go to Spear. We know that you're affiliated with them, but there are other places people can go. We're just interested to know, where do you think somebody starts? Is this something you can do in a day-long course, or is this something that you really need to go to a continuum like a Spear or a Dawson or Pankey or something along those lines?
I think that it's definitely not something that you can get in a day for sure. I mean, because one of the things is that I think it's a lot of information, and what we have to think about first when it comes to treating these patients is the patients themselves. And you're there to help the patient, and if the patient's in pain, then you need to help set yourself as far as skill-wise where you can help guide and direct. If you can't differentiate or figure out what you can do to help that patient, then you got to figure out where to send the patient. But as far as places to go, man, obviously, yes, I'm tied to Spear. We've got a couple of different TMD continuums, but I got a lot of my stuff from Pankey. There's a lot of great people, so a lot of times I find that it's a matter of reaching out to different people and finding who do you need to go see, and so there's some good courses out there for sure.
Mm-hmm. So I know we've talked about Spear, we've talked about Pankey and Dawson, and I know there's also Wes and I have talked about this course that Jeff Okeson does up at Kentucky, which is also, I mean, Wes, that's a pretty intensive course too that I know we.
It is. I have an orthodontist right up the road. I'm so glad that he's taken that because he truly understands TMD, and I've actually referred to Okeson about 4 or 5 patients over the 10, 12 years I've been in practice, and to great success. People have traveled 2.5, 3 hours to go see him into this TMD clinic. And but I feel like, too, that a lot of his treatment methodology, I just didn't feel comfortable with myself doing it. But now being able to, dive into a continuum course like Jeff is recommending, it sounds like Jeff is recommending that, you can't just go one day to the ADA and take a day course, and that may be why you don't see a lot of these big names out there that treat TMD. They're just kind of superficially just showing you, well, here's how you make a night guard, a good night guard, and maybe some principles behind that. But they leave you wanting more, and that seems like that even with a residency in 1 year's time, it's almost impossible with all the other things that you learn to really focus down on that those things that we really need to be doing as far as a deep exam and questioning of the patient. So I found like this is just really what you're saying, Jeff, and tell me if I'm wrong, is that you need a continuum to go to, whether it's Jeffrey Okeson, whether it's Pankey, Dawson, Spear. That needs to be the case. Is that right?
I think you're dead on. I mean, you do need a continuum, but I think the other important thing is that you need to develop a good set of mentors to work with as well, because one of the things is that the more you know, the more you see, and the more you see, the more you're going to start to treat and want to try to manage. And then, as you were just kind of alluding to, since you came back from the recent course, is that, oh wow, all of a sudden you start seeing all these things. And so with that being said, the same thing, you start going and seeing these things on patients and doing these exams, and then you start doing treatment, and then you start seeing different things occurring, and then you go, okay, well, what does that mean? And you have to have somewhere, someplace to start figuring those things out.
Like a decision tree. That's something we didn't even go into there at the end. That's why John and I have signed up for the next course already, is because we want to know more, Well, that is a great topic to discuss, and obviously it's very deep. I mean, I was always, blown away by whenever a professor gets up in school and they're like, there's been fights over occlusion. Like, I've seen people throw books at each other over this. I mean, have you heard the same thing, John?
Yeah, people get crazy about occlusion, and all these schools and schools.
Jeff, you're so laid back about it.
Yeah, man. You're not so getting angry about occlusion, Jeff. We appreciate it.
Flat plane, cuspid rods, Jeff? Is that what we're going for here?
Absolutely.
Condylar? Okay.
Yeah, so he's dogmatic, but he's not mad about it.
Dogmatic. I'm really not. I mean, the thing about it is that it ultimately comes back to the patient. And there's different appliances will work for different patients, and some appliances will work for some patients, and then there's some patients that no matter what appliance you do, it's going to work for them. So
this is great. Well, I'm excited about this next topic. And topic 3, everyday dental products. I mean, we have those things that we like to use.
Everybody was waiting for this. They knew we were going to.
You've got to ask.
They want to know. What's this guy
man.
think about
Look,
stuff?
We do the product and tip of the week. Now it's Jeff's turn. He is a dental guy. We are crowning him. Jeff, you are crowned
Very dental guy.
the dental guy of the week here. And so, here we're going to do the first thing I want you to do is I want you to name one indispensable, a product you cannot live
Strong
without.
words right there.
That's really hard. Only one, Jeff. What do you got?
Product or a piece of equipment? Because
it
piece
could be
of equipment or product, yeah.
Yeah.
Well,
let's hear it.
I had to say, earlier this year I acquired a cone beam, and I can say that's been a really big eye-opening piece of equipment. So,
okay.
Well, now you've got to drop some brand
Yeah,
names.
what'd you get?
We're not afraid here. Let's talk about it.
Well, I've got Plan Mecca. That's what I've got. So,
okay.
I've got the Plan Mecca Pro Max 3D.
Nice.
Okay.
And so been very pleased with it so far. So I've had it for, I guess, about 9 months now. So it's
okay. So now your main reason for purchasing this, not from a product standpoint, from a practice standpoint, why can't you live without this now?
Well, I mean, it's just simply being able to see things I couldn't see. Of course.
Like what?
Well, definitely now, rather than me talking to patients about joint issues and other things, I can go say, hey, let's go take a quick image of your joints and see what we got from a bony standpoint. But then the other part of it is it's a great tool for patients that have pain that's hit or miss, can't figure it out what's going on with the pain. It's amazing. Sometimes you find lesions and things.
The periapical pathology is ridiculous on this stuff.
Yeah.
So
that's what I'm seeing.
So are you catching stuff routinely, would you say, that it was missed, like as far as apical lesions or things that you would not have been able to see without it?
I mean, it's one of those things that to me it's amazing. I mean, I've got a case right now that when you look at the periapical, it looks a little fuzzy over the sinuses, and then the 3D image, I mean, it's really just black and white. It's really so. I mean, so.
I've seen the same thing, John, down here with patients. You send them something I'm having trouble diagnosing. And my assistant's now, she's pretty much just saying, send them for a cone beam. I have a relationship with someone where I get a cone beam with, but that's kind of inconvenient. So you've brought this into your practice, Jeff, and now you cannot live without it.
It's like I said, it's a great tool. And then, of course, implants. Of course, I use it with implants. I mean, implant planning. Implants are more and more mainstream. You have discussions with patients. They go say, hey, doc, I'm interested in doing that. What do we do next? Well, it was, you got to go to this other place down the street for them to do images. And versus now, it's like we can just walk up front and we can know here in the next 5 minutes we can look at a 3D cross section of your jawbone.
Has that sold more dental implants in your practice?
I think it has. It definitely has picked things up from that standpoint.
Are you placing or referring?
I place.
Okay.
Now let me ask you about referral, because the other thing is Wes and I have talked a lot about this, not on the show, but because I'm close. I'm looking at brands and things, and I don't want to get too much in the brand discussion because that could that could just derail this whole show with geeking. But
it would be bad.
But let me just ask you this: do you have now in your area? Are there a lot of other people that have cone beams? And if not, do you see there being, because people talk about, even maybe having this in your office for other people to send patients to you to take cone beams? I'm interested in what your thoughts are on that. Do you ever see that? And how do you handle that as far as from a liability standpoint? Or are you just kind of keeping this in office just for you?
I've been pretty much just doing it in office now. Yes, I have thought about venturing out, offering it to other offices. In fact, a couple of specialists there, a couple of the endodontists, they don't have them. And I say, hey, if you need one, I'll be more than happy to do it at a reduced fee. Just send them over and we'll shoot it. But to be quite honest with you, I haven't really had anybody sent over. I had one person that was actually a mutual patient that we did. But as far as people knocking down your doors going, hey, can you 3D my patient for me? No, that hasn't happened. So.
Yeah.
So 3D tomography, your most indispensable product now.
Nice.
Or piece of technology, really.
Yeah.
And
it's going to
feel like
it's going to get people looking at their bank accounts right now, Jeff. They're like, oh man.
Yeah,
you gotta have this. See, that's
especially you, John. And I'm building an office here, so
you can't.
I'm building room for one.
Right.
I've been wanting one
just
really
add
bad.
It to the, just add it to the loan. Why not? Right.
Right. Exactly. Maybe off camera we can talk a little about brands, because we could geek out about that. Now, look.
Well, this next part. So I'm excited. As we're talking about products, we gave Jeff a chance to really give us some back and forth because Wes and I we always love to get our little 2 cents in about stuff. But what we're going to turn it to now, as a part of the show, we want to call the lightning round, and this is basically we're going to do this for every guest we have on the show from now on, and this is where we're going to give our guest Jeff 60 seconds to discuss his thoughts on a product or an idea or something that we're gonna just say the words, and then Jeff's got 60 seconds and we're not going to say anything. Wes and I are going to try to restrain ourselves, not going to say anything. So that's hard.
It's going to be hard.
It's going to be hard. Okay, so the first product or the first segment of this 60 seconds is, Jeff, what is your composite of choice?
Well, I can tell you what I use every day. I use actually a product called Majesty. It's from Clearfield. That's my primary one. It's my go-to. It's a nano-feel composite. Has great handling. Finishes up nicely. And quite honestly, kind of fell into it from getting a few free samples, and then next thing you know, that was kind of primarily what I was using. As far as my interior stuff, I mean, I'm still old school. I still use Renamel microfills. So Cosmodent, yep, it works great, polishes up great, and every time I see the patient come in the door, it's still shining. So can't have any complaints about that.
Nice,
fantastic. How about bonding agent?
Well, I can say that I converted over about a little over 2 years ago to Scotch Bond Universal. I've been using that for about 2 years now. A lot of the guys out there at Spear turned me on to it. Actually, Frank and Greg Kinzer and a lot of those guys were using it, and I heard nothing but positive things. And I said, hey, I'm open to trying something different. Before that, I actually used Clearfield SE Bond and used that for a number of years, and still see some of those patients that I put those restorations in 10 plus years ago still doing great. So can't argue with either one.
Excellent. Okay, digital versus conventional impressions.
Well, right now I'm doing conventional impressions, but that's going to be my next purchase. Is going to be digital impressions. I think that's the going to be the next evolving thing. You can either choose to do a CAD/CAM machine or do digital impressions, and I think that it's here. Digital impressions are here. I think what I'm hearing from everyone, they're doing an excellent job as far as capturing images. They're quick, they're patient friendly, so I've heard nothing but positive. So that's the next on the list.
Number 4, Emax or zirconium?
I will have to say I'm probably 90% Emax. I may use some zirconia and second molars, but I think I've, knock on wood, I've only just seen 1 or 2 Emax fail over. Probably I've been using it solidly for the past 6 or 7 years, and I've put it everywhere from front teeth to second molars. So.
Okay. What about guided surgery for implants? So you kind of alluded to this with your cone beam, so I think I know what you're going to say. But guided surgery versus freehand, what do you think on that?
Guided surgery, hands down. That's one of those things that over the past year since I've got my cone beam, I've really gotten into doing guided surgeries with Simplant. And I'll have to say that I work with a friend of mine who's an oral radiologist, and that's just been a phenomenal learning experience of working together online, placing the implants, looking at anatomy, and hands down, it makes the surgery I can be in and out very quickly when the guide is all set. So,
well, number 6, how many assistants do you have and their roles?
I've actually got 1 full-time assistant. I got 1 part-time assistant. I have the full-time one is there obviously throughout the week. The other part-time was there 2 days a week. As far as the roles, obviously handling, managing everything chairside, stocking the room supplies, getting the patients back, seated, getting the rooms turned over, sterilization, lab work. She's really busy. So
Cool. What about endodontic file systems and obturation systems. I don't know how much endo you do, but if you do some endo, tell us what you use.
I'm partial to Brasler system. I've been using the EndoSequence file systems for probably 5 or 6 years now, and recently kind of converted over into their Brasler. It's an obturation system that they use. It's a glass ionomer that bonds to their gutta-percha points, and so far so good. I really enjoy it. Good fit, nice feel. So good success so far.
We're blazing through this. Number 8, cemented versus screw retained.
It's a hard decision, but actually cemented. That's majority of what I've been doing. So place custom abutments where the cement interface is in a good location, and so that's what I've been using. I will say that probably screw retain is still an excellent restoration, and I think that with some of the things that we're seeing with drifting of the teeth and contacts opening and other issues that we see, that screw retain and retrievability is definitely now a topic.
Can I ask just real quick as a follow-up to that? What do you cement?
Coming,
what do you cement with? I have to ask that. What if you do?
I knew you couldn't.
I have to. I'm a big Chandra Wadhwani guy in cement. So what do you cement with? With your
wait a minute, Jeff.
Implants.
Here comes the geek question. He just landed a fancy name. John likes to do that.
Thanks, Wes. I appreciate that.
Do.
Name dropping.
No, I'm throwing it back at you now, dental guy.
I know it's bad. Okay, so all right. So we're ruining the lightning round. I know that, but I just want to know, what do you cement with?
Well, it depends on where I'm at. In other words, oftentimes if it's a restoration like a porcelain fused to metal, or if it's a posterior restoration zirconia based, a lot of times actually I'll use vinyl. I know that kind of sounds crazy, but it's an older cement, and most of your retention resistant forms come from the restoration as well as the implant abutment. Anteriors, oftentimes I'll use a resin cement because of just show through and other things. And of course, there again, I'm very careful about lining it, making sure I express out the excess cement and everything else. So,
okay. What about immediate versus delayed loading for implants? How do you feel about that?
I do both. It's one of those things that I've done a lot of immediate anteriors. I think all the conditions have to be right, and then right patient. Are they bruxer? Do they have a lot of wear on their teeth? Does the implant have excellent stability upon placement? All those different factors play into it. And then, of course, delayed loading. I mean, for the most part, when it comes to a posterior tooth, I try to do a delayed loading. Most of the time, single stage placement. So,
cool.
So, single stage meaning cover screw, let it heal.
Single stage with a healing abutment, actually. So they leave with the healing abutment through the gum tissue. Yeah.
Okay. So, number 10, your favorite hobby.
Oh, that's easy. So I'm an outdoorsy kind of guy, so I love to hunt fish. So
nice. That's right up my alley, man.
All right. Well, good.
Hunting and fishing. Language. Yes. Oh my goodness, man. That is my love language.
I know, man. A bow and arrow or gun, whatever it is, right?
I'm practicing my bow right now because next month, man, I go bow hunting. Jeff, what are you drawing?
Yeah, it's funny you say that because I actually we're still moving some stuff out of our house. We just moved a couple of months ago, and I was still moving some stuff out of storage, and I got my bow out, and I was actually I shot a few times out there. It's been a little while since I shot.
What kind of bow do you have?
I've actually got a Hoyt. So
really?
Yeah.
So is it one of the double arms?
I'm sorry, it's not a Hoyt. It's a Matthews, believe.
There you go. So, now you're speaking my language.
Yeah, it's a Matthews. So,
yeah. So I hang out with these guys from Wisconsin, and we went right down by where they make, do the Matthews thing, and they have the factory right down the road, and went to like a Wild Turkey Federation thing, and they were giving away Matthews bows like crazy at this raffle. It was unbelievable. I thought I was going to win one. I was so close, but it was pretty cool.
Oh, that's cool.
Geeking out. All right, sweet. John?
Well,
What do you think about that? That is so hard for me not to say anything.
I mean, I could, I messed it up with the cement thing, and I couldn't help myself.
No, that's okay. But you dropped names.
I know. I had to.
You got serious. That's going in there.
I got to know on the cement with the implant thing.
Well, that's it, man. We could go on about that.
Yeah, but no, that was great. I mean, we had some good stuff in there, and I think that for everybody that's listening, again, you get somebody like Jeff on the show who is. I mean, Jeff's not going to say this himself, but. To go through Pankey training, to go through spear training, Jeff is at a very, very high level, we know, practicing dentistry. And so somebody like that comes on here. A lot of people, of course, dentists, we all want to know, like, we're gear people. We want to know,
that's right.
What are you using? What's working for you? Because that's stuff that makes you think about even, for next week, things to look at, products to look at. So we're interested for, again, people that are listening today, about what Jeff had to say, a lot of the things he had to say today. Give us your feedback, give us some comments on that. We'd like to know what your experiences were with some of these products. But yeah, Wes, man, that was good stuff.
Well, let me just tell you, Jeff, we really appreciate you coming on the show. I will say that we have crowned you one of the dental guys,
right,
and we're excited about that, to have you in our Dental Guy Hall of Fame. Jeff Lineberry,
nice.
Faculty member at Spear Education. Thank you so much for being on the show. It's been fun talking to you tonight.
Thank you, guys. I really do appreciate the invite. Enjoyed it as well. And
hopefully we can do this again sometime.
Oh, I'd love to. It's fun. I enjoyed it.
The topics that we discussed here in the last 10 minutes, I mean, we could go on. I know John and I were just itching to say, well, what in the world are you talking about here? Tell me why you use that. And, man, you're using some very high-quality things. But, John and I were really excited about tonight, guys. And again, we want you to, right now, if you're watching on YouTube, we want you to hit that subscribe button, share this across your social media atmospheres. I want you to go down into the comments section, and you'll see our Twitter and Facebook. Go on there, like our pages, post this, retweet. And, man, it's been a great show, John. I'm so excited. Thanks on behalf of John, on behalf of Jeff Lineberry, Honorable Dental Guy. We are the Dental Guys.